Welcome back to the Waiting Room podcast, brought to you by onlinedoctor.co.uk. Today, we're diving into women's health in primary care, a space where so many important conversations begin, but often don't get the time or clarity they deserve. Our guest is Dr Harriet, a practicing NHS GP with a special interest in women's health and menopause. Harriet's also part of a family full of doctors, so we're excited to hear more about what drew her to general practice and what she wishes more patients knew when it comes to managing their health. Dr Harriet, welcome to the podcast.
Thank you. It's so good to be here.
So you've come from a family of doctors. Has being a doctor always been on the cards for you?
No. I wanted to be a vet for a long time. And I went to a vet practice when I was about 15 to do a bit of work experience, and they had to put a dog down, a very old dog, and she was lovely and very old, and it was absolutely her time to go, and I cried for 4 days after.
4 days?
Yeah. And my mum said, I don't think it's for you. So I was kind of gently nudged into medicine. I come from a medical family and I come from an Asian family. My father's Singaporean. And there is that slight kind of expectation that if you have a child that does reasonably well in school, good grades, that kind of thing, they're either going to medicine, law or engineering. And medicine seemed the most appropriate one. I think a lot of people say I went into medicine to help people and I went into medicine for all these noble reasons. I have to say I was nudged in. And I also wanted to be just like my sister, who was also studying medicine. So that was the reason why I went in. But I'm really glad that I did, because it's been the best decision of my life. And I love my job and I love my career. So I'm really glad that I was nudged in rather than just kind of deciding that for my own path, because when you're 16, 17, you don't know what you're doing with your life. So it wasn't always on the cards, but I'm really glad that I was encouraged to do it.
That's a really honest answer, because probably the same for me.
Yeah.
I went to a school where pretty much everyone came out lawyers, doctors,
it's
engineers.
Just expected, isn't it?
And if you're good at science, you'll be there. And sometimes it was like a case of you're just on a treadmill, and not always to a destination you're choosing.
Yeah.
But it's so lovely to see that at the end of that path, you've really enjoyed where you've landed.
Oh, yeah.
And you've landed in GP, general practice. What made you choose that specialty?
I quite liked the autonomy that it gave me. I suppose it's probably not common knowledge, but in the NHS, in the way that doctors in training are allocated jobs, if you wanted to do, say, for example, surgery, you pick like an area of Scotland or an area of England, and that area can be quite big. So I wanted to be a surgeon for a very long time. But one, there weren't that many training numbers in the area that I wanted to work, and I didn't want to go and work very, very far away from my family. And even if I did get a number or a training post in that one area, you'd be at hospital for 6 months, say in Dumfries, and then the next one would be in Ayr for 6 months. That's like 2 hours away, So there was that. And I loved with GP that you did so many different things. I loved all of my rotations as a doctor, and every single one that I did, every ward I worked in, I was like, this is it. This is what I want to do. So I always knew I would be a generalist of some sort. But GP just gave me that opportunity to do lots of different specialties, and I felt like it gave me choice over my own life, choice over my own hours. Choice over my own team as well. You've got a bit more control over who you work with once you finish your training, and I'm just I have no regrets. I love it.
I love that. Mm-hmm. So basically, with the general practice, you get more choice as to where you can live. Yeah. Because there's a lot more job opportunities. Yeah. So you're not necessarily separated from your family. And that's a big part of deciding on what you do. Yeah.
There's a lot more GPs. 90% of healthcare happens in the community. It doesn't happen in hospital. So there's a lot more places to work. There's only 1 or 2 hospitals per county, isn't there? So there are physically more jobs, and there are physically more locations, because most towns would have at least one practice. So I like that, and it's a hugely varied role. You're never bored, and you get to do really interesting things.
And you have been able to specialise within that, because you have a special interest in women's health, don't you? Yeah. Is that one of the parts that you love most about general practice, or is there anything else? I really love it. I think that most female GPs will be slightly not forced, but most women, when they're coming in to deal with female health, will come in and they'll ask for a female doctor. Yeah. So the majority of female GPs will have a lot of experience in this area.
I really liked it because I find it one of the most rewarding types of consultation and one of the most rewarding groups of people to work with. So it kind of grew arms and legs from just really enjoying it. And I suppose I'm quite chatty and lots of women come in when they come in to see their doctor about something that's a bit more personal, hormones, periods, contraception, pregnancy. You have to talk about things that are quite personal and intimate, and I'm quite chatty, so I think that kind of bred an atmosphere where people felt like they didn't feel too awkward, I suppose.
And do you find that that's why you find it so rewarding, but it's also rewarding for your patients because they're not easy topics to talk about?
No.
So to come across someone who's excited to offer that care, offer that help, offer that education, and also make them feel comfortable must be rewarding on both sides. Yeah,
it really is. I think that, one of the best things about doing lots of female health is that you get to lift other women up, and it's I really enjoy that. I really enjoy making other women feel better because I think a lot of the time we're not necessarily good at doing that for ourselves because we've got so many different pools in our time and our attention and our energy that you often don't present with your own symptoms. And when women do finally they do that and they feel heard and listened to, it's really nice seeing someone just breathe a sigh of relief and being like, oh, like someone's listening.
That's a big part, isn't it? Feeling heard.
And
so it's amazing that you're able to provide that. But do you find that your role has changed over the years, or the role of being a GP, especially with constraints and time pressures with the NHS? Have you found that harder and harder?
Yeah, I think that it's, the majority of GPs have 10 or 15-minute consultations. We have 15. Lots of GPs still have 10. And to do, a consultation on contraception and speak to a young girl who has never even thought about contraception before, to cover all of the different types, what it can do to you, how it works, how to take it, miss pill day rules, all these sorts of things. There's no way you can do that, plus your notes.
Plus them walking into the waiting room.
Plus them coming into the waiting room, plus prepping for your next 10-15-minute appointment. You can't do that in one appointment. And there's different tips and tricks of how to make the most of that consultation and also how to make sure that patient is well informed and can follow things up. But it's not really feasible to do these consultations in a way that they deserve. Menopause as well, these sorts of things. These are big topics and important topics and topics that influence women's lives for years. Contraception from, if you start at 18, 19, how long are you fertile for? Till you're in your 40s. So those initial consultations, which are to do with information gathering and giving information to the patient, are really, really important, and it's really hard to do that in a short consultation.
And do you find that's getting harder and harder?
I think so.
You're probably getting more skilled with experience on how to best manage the time that you have.
I think I'm getting slightly, I haven't been a GP for that long. I finished my training in 2021, is that right? But I think I'm getting slicker at giving the information, and also kind of judging when someone comes in. You can almost start to understand from the minute they walk in how much of a basic understanding they have. Some people come in knowing nothing, and other people come in saying, with all of their questions already written down, which I always love. So you can
That's
kind
good
of,
to know
I love that. No, it's
because
really, really helpful.
Sometimes you think, I've come in with too many questions. Am I bothering my GP?
No, never.
Am I doing this?
No, I love it when people come in like well informed and keen to be involved in their in the decision making. So I think that's been getting easier. COVID had a big impact, I have to say. I think pretty much all GP practices in the country went to a triage-based system when COVID hit, and the majority of consulting was telephone-based. There's pluses and negatives to both sides. Since COVID, we have moved much more to like a hybrid system. So prior to COVID, we just saw everybody face-to-face. When everything was quite telephone-based, we found that some people didn't like it, but lots of other people, particularly the working population, people who perhaps maybe were at uni, like far away, but didn't want to change their GP because that's been their GP for ages. People who just maybe were busy, had time constraints. they loved being able to deal with it on the phone. Do you know? And so after COVID settled down and we had a decision as a practice of how we would change our appointments, we changed it so that we offered people the choice. When someone calls in, they say, do you want to see a doctor or do you want to speak to a doctor? Yeah. And we have about a 50-50 split, and that reflects our patient population. So I think that there has been changes in the way that we consult because of time constraints, and just, things like COVID that changed how we do it. And I think actually we've got a much better balance for our patient group now.
I think offering telephone consultations is so much more practical as well.
Yeah.
But it sounds like you've had to adapt a lot in the last few years since during your studies and after as well. So well done.
It was a side of going into general practice that I didn't expect. Yeah. So I knew about the clinical stuff, and I knew that, you would have to see lots of patients, and I knew that I'm a GP partner, so I knew that there would be a bit of business management and staff management. I did not expect to have to think so flexibly all the time. Yeah. Not just things like COVID. Obviously, COVID was like a steam train and knocked us all for six. And I think we adapted really well. But, even just like your patient demographic changing, there's been funding pressures recently from Scottish Government. So some of the funding that was there was promised hasn't really come. So you have to think quite flexibly around how you're still going to deliver the care that you want to give. So. Yeah.
Well, let's talk about some of that care, because we want to talk particularly about women's health. So we want to start with contraception.
Yep.
What kind of, tell me what's most common when someone comes in and they want to talk about contraception? What is it that they most often want to know? Are they normally on contraception and they're not happy? Or is it a case of they just how did it start? Some people don't even know that they might need contraception. How does that conversation normally start for you?
It's normally a mix, and it depends who comes in. Yeah. Unless somebody is relatively young, most people will have tried something. Yeah. And I think the thing for me is trying to understand what someone has tried and also whereabouts they are in their family planning journey. So women who have just had children, for example, might want very different types of contraception to, women who haven't, or girls who are coming in, or young ladies who are coming in when they're at uni and they're not with a partner and they're just in that stage of life where they're like, babies are just nowhere on the horizon. Yeah. You have a slightly different consultation than perhaps a lady who, might want children in a year or less than, and perhaps are with a regular partner and they're working. So contraception has to work with your lifestyle, I think, is the main thing. And there's lots and lots of different options for that, but it's something that women have to take for a long period of time, and it needs to work with you and for you, not against you. Absolutely.
And I think there sounds like there's a lot more types of contraception than some people might realise. Can you give like a brief overview of what's available? Yeah,
so I normally break it down into hormonal based contraception and non-hormonal based contraception. Yeah. So if you start with hormonal based contraception, everybody's heard of the pill. So there's the pill.
But even then there's different types of pills.
Yeah. So there's, as a broad brush, there's two types of pills, one which contains just progesterone and another one which contains estrogen and progesterone. They work slightly differently and you take them in slightly different ways. But most people who come in, you say, have you heard of the pill? And everyone says yes. Talked about it in school, these sorts of things. Then you can get an injection. So that's every 3 months. You can get a coil. There's a hormone-based coil and there's a different type of coil, which is a copper coil, which doesn't have any hormone in it. And you can get an implant, which sits in your arm as well. So that's the main kind of hormonal types of contraception. Non-hormonal based contraception, I mentioned the copper coil. There's also condoms, so that's just a simple barrier. You can have a female condom as well, which people don't tend to use that often, but it's definitely worth mentioning. And there's also something like natural, like tracking your cycle. Yeah. So there's I do talk about that quite a lot, but I tend to it's for women who are in my opinion, for women who are in a very particular stage of life. Okay. So
if they did fall pregnant,
it's not going to be a disaster. Okay, exactly. Yes, yeah. So and tracking your cycle. If you have a regular cycle, it can work really, really well. Yeah. If you're with a regular partner and you're in that stage of life where think you're in a routine and you're with a regular.
And the tracking can be used on the flip side if you're actually trying to.
Yeah, exactly. If you're trying to, and there's really good apps like the Natural Cycle app is really, really good. And that's becoming very popular. Just using essentially just tracking your cycle and avoiding having sex or unprotected sex when you're ovulating.
But they all have risks or have downsides or positives, don't they?
Yeah.
Just like, as I'm sure, my basic understanding is obviously using this tracking system is it's definitely has a lower success rate or lower prevention rate. For taking the pills, whichever pill it is, you've got to remember to take it. Yeah. Condoms don't always are effective, or you forget last minute. Yeah. Having injections, it's hard to reverse it. Yeah. So forth. So do you find you have enough time to talk through all those different options, or do you find that you can kind of pick up quite quickly, or most women have an idea of what they want and it's a bit more straightforward? Yeah.
So say if it's somebody who has absolutely no idea, or no idea is probably not the right way, but no sort of no preconceived sort of expectations of what they want. They're open. They say, tell me what's available. Yeah. I tend to break it down, so I will normally have an appointment where I tell them about their different options. Then I tend to give them either a website or give them a bunch of leaflets to go away, and I tell them to not make a decision at that point, because it's a huge amount of information to give someone. And because there is a lot of information to give someone, you kind of almost just go blah and tell them. And then this girl sometimes, and bearing in mind that the girls or the women who are coming in who haven't tried anything before, they're often quite young, and you've got this 18-year-old person next to you who you've just talked at for 6 minutes of all of the different options they are, and they often look quite overwhelmed. So the one thing that I would do is I never really ask people to make a decision right there and then. I tell them to go away, think about it, please be sensible and don't get pregnant while you're thinking about it. And then I tend to follow them up either with a phone call or something a week later, once they've had time to process the information, think about some questions, go and do their own research, which is so, so important, and then come back having made a well-informed decision. But
that's it. It's such a big decision because it's something that could be on for a long time. Yeah. So you can't do that in 2 seconds. Yeah. You just said do your own research. Yeah. But that can come with problems as well, because there's a lot of misinformation out there, isn't there?
There is.
Come across. What do you wish people listening to this stopped believing?
I think that the big one at the moment, which is coming from social media, is that contraception can affect your fertility.
Okay.
And there's more and more people coming with that concern. And I think it is quite a big myth, and it's becoming quite, lots and lots of women are not going on contraception because they're worried about their fertility. The majority of contraceptive options, if once you stop taking them or get a coil out or something like that, you tend to get your natural cycle back within a month to 2 months. The only one where that takes slightly longer is with the injection, but that's because the injection works over a 3-month period. So you get the injection, it's due to be renewed again in 3 months. Yes. Therefore, obviously your cycle is going to take a further month or two after that. Okay. So that's a big thing. I think a lot of people are doing their own research through TikTok, Reels, that kind of thing. And there's lots and lots of people on social media, like doctors, scientists, like consultants, who give really, really good information, but there's also a lot of people with what they're saying isn't evidence-based. So I really, really like it when people go and do their own research and think about what they want and what's best, but
from reliable
sources, NHS Inform, patient.co.uk, like these sorts of like really good, good sites, and it's that's the thing that I would probably like to encourage people towards, is making sure that where you're getting your information from is from a trusted source.
And so obviously the misconceptions can create some challenges for you, also for the patients to access care if they're misinformed. Do you think patients have other kind of challenges or barriers, like difficulty getting an appointment even, or supply issues? Are you finding that that's an issue?
Yeah, so difficulty getting an appointment is a huge one, and there's a lot about that in the press. I think that every GP is different, and the way that you can gain appointments are very different. Yeah. You can, in most practices, any GP can give contraception or do a contraception consultation, and as well as the practice nurse should be able to do that as well. And although appointment systems may differ, I would be very surprised if you can't get any sort of appointment for contraception. If there is an absolute, if you're, for whatever reason your GP can't facilitate that, which shouldn't happen because it is part of our GMS care, GMS being the care that we are expected to provide for every patient, standard care, you should have access to a local sexual health clinic or family planning clinic. But you know, GP is got lots and lots of funding issues, but the idea that we can't even provide contraception just shouldn't, I don't think should happen now. Obviously, I
talked about my own story before we started recording, where I've, happy to share what I use, but I've been on the hormone coil since I was 19. Been very fortunate that I had no fertility issues, had my children and I had it back in, but my primary care couldn't provide that service, so I had to go to the local sexual health clinic as well for it. But there are ways, but it creates more barriers, doesn't it, when you have to go and search it out. Yeah,
and I think, I work primarily in the NHS. I know that there are private clinics that can provide advice and consultations and can do coils and things like that as well. I haven't worked in any of them myself, but I know that it is an option. Yeah. And perhaps those clinics might have a little bit more time. Speaking from personal experience, the way our appointment system works is that I am able to, talk to somebody for the appointment time and then call them again in a week. And we have the facility to follow people up, and we have the systems to do that. But we currently, touch wood, don't have any staffing issues, these sorts of things. So, and I'm aware that not every practice is in the same fortunate position as what we are. So the way that I will the way that I'll talk about the way I do things might not necessarily be what everyone's experience is, because not everybody has lots of staff and lots of appointments.
So it's important to talk about. Mm-hmm. I'm going to move on from contraceptives and talk about another big topic that I'm sure you face all the time, and that's periods. What is it that most patients come to you regarding their periods? What's the topic that they most present with?
I think probably either a change in what their normal is, or not knowing if what their experience is if that is normal. That was perhaps put wrongly. So people often come to you saying, I'm getting all of these symptoms. Is that right? Yeah. Is that normal? Because none of my other friends seem to be getting this. Or the change. So someone noticing that something is a bit different. Yeah.
So what is normal, or is that quite varied? There's a lot of normals.
There's a lot of normals.
Okay.
There's a lot of normals. And I think women as a whole are very good at knowing their own bodies. Yeah. So say someone gets their period, starts their period, 13, 14, 15 or something like that. Within about a year or 2 years, your hormones will settle into a natural rhythm, right? So the majority of women will develop a monthly cycle, and they'll get to know what their normal symptoms are. They'll know how heavy they bleed, how light they bleed, whether they need to use pads, tampons, they'll get a bit moody and spotty, and they'll know their period's coming. They'll know how often it'll come.
All the fun stuff.
Yeah, all the fun stuff. And they'll get to know that. So the majority of time, people will present with, I've had a change. Yeah. And that change might not necessarily on paper be worrying, but if it's different to what their normal is, it's quite important to listen to that.
Okay, so it's good if someone has a change in what is a usual regular cycle and symptoms, they should come to see you. Is there anything else that you would say, if you have X, Y, Z, I would really come to see a GP?
There's a few kind of what we call red flag signs. So bleeding in between your periods shouldn't happen. Even if it is just spotting, even if it is just that kind of funny brown blood that you can sometimes see, that's still bleeding. So that shouldn't happen. Bleeding after sex shouldn't happen. We call that postcoital bleeding. That would be one of our more kind of red flag signs. Anything, really, really painful periods that make you have to take time off school or work, that shouldn't really happen. Yep. There's some women who have certain conditions who, things like endometriosis that will result in that. But if you don't have anything diagnosed, your period should not be making you take time off school or work or from social activities. Really, really significant pain during sex is a bit of a worrying sign. Not necessarily anything that could be serious, but it might be worth us knowing. And any sort of change in discharge as well in between your periods, we would want to know about.
I think some people have almost normalised some of those symptoms. What do you want to say to those people?
I know. Sometimes people come in and they'll say, I've had my period's just been awful and I'm having to take time off work and I'm using all these painkillers. And you say, oh,
as you do, they probably say.
And then you say, oh, when did that start? And they go, oh, about 3 years ago. I'm like, what? How have you been struggling with this for 3 years? But that's just women, we don't come to the doctor for ourselves. We're very bad at that. So yeah, I think, and if you start off with if your period starts off with these sort of symptoms, that becomes your normal. You think that is just how your period should be. Or women who are very young when they start, just obviously things are quite irregular. So, and therefore they think their period will always have to be irregular. Yeah. And actually, if you're not in a normal cycle, it is a sign that like your hormones are slightly off. So I would say everyone has their own normal, but if you see a change to what your normal is, even if it is within those boundaries of normal, we would want to see you. Any of the red flag signs, intermenstrual bleeding, postcoital bleeding, really bad pain during your period or during sex, funny discharge, itching, we want to know about that. And just don't sit at home and worry, or don't just wait, oh, next month it might get better. Oh, next month it might get better. Because they'll be 9 months down the line and it's still not better, or 13 months down the line, or 3 years down the line. And all of a sudden you've gone, oh, 3 years of me like having flooding bleeding and having to change my pants and stuff like that.
The reality is that a lot of the time there is something you can do.
Yeah, we can do stuff to help. Exactly.
So, they don't have to be sitting like that.
No, and it doesn't necessarily mean that anything worrying is wrong, but we can still do stuff to help. Do you know? And it shouldn't be something that you dread every month. It shouldn't be something that takes over your life either.
But it's obviously still a big topic, like what we talked about with contraceptives, someone coming in with their periods. As a GP, what would you love your patients who are coming to an appointment on topic like this, what would you like them to have prepared, or to do you know, everyone to you with information? See, when people come in and they say, I Googled my symptoms, they always say it with an apologetic tone. They say, I'm really sorry, I Googled. And I always go, no, I love that. I love it when people come in and they have taken that kind of personal interest into their own health. They've done they come in and they say, I've Googled and I think it might be this. And you go, excellent, let's talk about that. And that means you can either say, you take your history and you can say, oh, do you know, I really recognise and I understand why you think it's that, but I don't think that's quite right because of these reasons. Or similarly, you can talk about that expectation, and as well as them thinking it might be that, you can also talk about things that the other things that it might be. And then it means that people can make well-informed choices. So we talked about 15-minute, 10-minute GP appointments. One of the best ways to utilise that time properly is coming in with a list of questions and coming in with a list of concerns, not a list of different conditions, but a list of what's worrying you.
Of what's
so you can
worrying
have
you.
It allayed or addressed.
Yeah, exactly.
Because there's nothing worse than, I did GP back in the day. That's, you spend the whole time in your mind, it's obviously this. It's barn door, obviously this, but the patient's somewhere gotten worried that it's something else, but they don't voice it, and they still go home worried, or they might bring up the end, and then you don't have the full 10 minutes to be able to go, okay, let's address that concern. So ideas, concerns, expectations.
Absolutely,
kind of coming with those and just being really clear with those so that you can get the information you need.
I think people often come to the GP as well worried that they're going to be told something terrible. Do you know? And they'll come in and they'll give you a list of their symptoms and they'll say, I'm worried about this. But actually in the back of their mind, they don't want to say it out loud, but they're worried they've got something scary like cancer. And sometimes you can pick that up in someone and you can ask them, I'm quite direct with my patients. So at the end, if they're still looking worried, I'll go, you still look worried. Do you know what's going through your mind? And then they'll say it. You have to sometimes push someone to say what it is that's really worrying them, because they don't want to say it and then you go, oh yeah, well it might be. But
it's also hard if that comes up at the end of the time.
So you need to be able to have time to tell them why you don't think it's that. You have to be able to explain to someone, like all of the reasons why, you can never say never, but all of the reasons why it's incredibly unlikely, and you can alleviate that fear for them.
A big part of being a GP is actually that reassurance for someone in their family, as opposed to not just diagnosing and providing care. But obviously we're talking about periods. Would you find it helpful if patients came in with like their normal cycle length and when their last period was, and other symptoms associated, if they had that written down? Would you find really helpful? Anything else you'd add to that?
It's really helpful to know, and also things like mood associated problems with periods are quite big now, and there's a bit more awareness. There would be always that kind of eye-rolling husband that's like, oh, she's clearly going to get her period soon. and actually sometimes it can be helpful for women to kind of track that. You know, like I get really teary 3 days before, and you can talk a little bit more about how, you know, certain types of contraception or certain types of you know, symptom management can help that. We talked about the Natural Cycles app, and there's this, I'm in no way affiliated to Natural Cycles, it's just the one that I personally use. Okay. But there's lots of different cycle tracking apps, and historically women would write it down in their diary. Yeah. Do you know, when you would have like a paper diary and they would put like a little red dot
3 days before the full moon.
Exactly, yeah. And you would have like a little like P for like written in red for period. Now we have apps and they're actually really helpful. So even if you're not using it for contraception or for like family planning, these apps are really good for and it's for tracking your period. And it's quite helpful when someone comes in with a change in their period, and you can look at the app. They can show you in the app when they've bled and when they haven't, and that's actually really helpful. So these are quite good. So, but a list of questions and some sort of idea, if it's to do with your period, of what has changed from your normal is really helpful.
That's awesome. The other topic we wanted to discuss was cervical screening. Obviously, there's recently been a change in the intervals between screening in the UK. Yeah. I believe it's 1 to 5 years if you've not been diagnosed with HPV. Is that correct? Yep. Mm-hmm. What are your thoughts on that change?
Every change is evidence-based, and I think when it was every 3 years, I think the pickup rate was probably slightly too low for the NHS to keep justifying that time interval. Yeah. And everything in the NHS has to be balanced with how much are you picking up as opposed to how much is this costing. And sadly, you know, money's a big thing in the NHS. So it may be that increasing that interval period to 5 years, you may perhaps miss the odd one, but I think that the reasoning behind, or the communication from the health board about why that was done, was because the numbers that they were picking up were so few that they couldn't justify the cost of the 3 year interval period.
Well, the reality is it's not the 3 to 5 years, maybe missing 1 or 2. Most reasons we might not catch something is because people aren't getting screened.
People don't go at all. Yeah, people don't go at all.
And what's your experience of that? Having talking to patients, you know, you're obviously seeing if someone's not being screened, maybe encouraging them to. What are the reasons people are often telling you that they're not going?
It's normally fear. I work in a fairly deprived area of the west coast of Scotland, and we know that levels of deprivation can they tend to, women who come from a more deprived community tend to not appear for their cervical screening as much. Okay. Whether that's to do with education or access or fear, or I don't know.
Fear of what? The process, or fear of the result?
Both, I think. Okay. The big group of women where they really don't come is women who have had some sort of sexual trauma. Okay, so that's the patient group who really just do not attend, and they're really hard to reach out to, and it's a really tricky thing because you totally can understand why they wouldn't want to come. I don't know how services are kind of more broadly in Scotland, but for example, in Glasgow, there's the Sandiford Clinic who have a specialist like clinic for women, for a cervical screening clinic for women who've had sexual trauma, which is, it's really good, and we can refer to them. But I think the thing is more broadly, so that's one of the big reasons, but in general, lots of women cervical screening rates are going down, so they're dropping. And that's not just in that small cohort of women who've had something awful happen to them, that is just in general, women aren't turning up. I don't know whether that's because of a lack of trust in GPs. There's a lot of problems at the moment with, you know, perhaps you have to go for your cervical screening and you don't know who's going to be doing it. You know, a woman who you've never met before, who you have to just go, right, pants down and off you go. And it's a very intimate thing, isn't it, for someone who you've never met? It's not comfortable. No. I think people always think it'll be sore, and it shouldn't really be sore. No. It's never going to be totally pleasant or comfortable. But the thing that we hear most of all is, that wasn't as bad as I thought it would be.
Okay.
So particularly with women, when it's their first one, they all come in really worked up, understandably, and they get it done, and it's such a quick thing. Yeah. And then it's done and they go, oh, that wasn't so bad, was it? And I think the thought is worse than it actually happening. Yeah.
And especially if it's only every 5 years now, you know. Yeah. Just do it. The benefits outweigh. So what are the benefits of getting your cervical screening? Yeah,
so we can pick up things like HPV infections, which can predispose you to cervical cancer. And obviously we can pick up early cancerous changes within the cervix. Yeah. this is really important because with like anything in medicine, prevention is better than cure.
And actually, even if early is found, there's a lot that can be done. It's much better than waiting till someone has symptoms. So some people I think might be scared of, what if they pick up early signs? Well, actually, there's a lot that can be done at that stage as well.
And early signs are common. Do you know, we see it quite a lot, and we don't see lots of cervical cancer. We see a lot of early signs, but we don't see lots of full-blown awful cervical cancer. And I think that's because when you pick it up early, there's lots that can be done. And then when you pick up someone who's got early cancerous changes, they get increased screening, so you get offered a smear slightly more often. So it does work. I think lots of women are also embarrassed, and you know, I've had 2 kids. I'm not embarrassed at all. Do you know, once you've had children and these sorts of things, you just go, yeah, it's fine. But legs, you know, it's legs up and off we go. But there's see women who haven't had children, or perhaps just are that predisposed to feel a little bit more self-conscious. They're just very embarrassed. But honestly, see someone who does women's health all the time, and indeed for the nurse, it's normally a nurse who does it, who will do a whole clinic of cervical screening. You might as well be as looking at someone's elbow. Do you know, like, it's like,
I always use that analogy as well.
Do you know, see all that, it's, you know, we see it so often, and we see so many different women, so many different bodies, that it's like examining someone's hand. And we're always very aware that it's very embarrassing for that person, but for us, it's just another day. It's just,
it's reassuring for everyone listening who might have been not gone because of fear or embarrassment, or worried that it would be painful when it's not as bad. But also, as we said, a lot of people might go because they might not understand why it's so important. So we've really covered all of that. You also mentioned HPV, which is obviously predisposes you to higher rates of cervical cancer, and that you can have that screened at the same time. But there's also the HPV vaccine that's coming through, isn't it? Do you want to talk about that?
Yeah, so the vaccine is offered to girls in schools, actually. And you can obviously opt out. The majority of people are vaccinated against HPV. If for whatever reason you haven't had it, there are certain criteria where you can get it as an adult. People who are slightly higher risk of developing HPV infections, you can get that as an adult. But the HPV vaccine is really important, and it's really important to, I suppose, I think a lot of people feel like you have to have sex to get this infection, and it's not just intercourse that can give you the infection. So other types of sexual activity can give you the HPV virus. So, and
interesting. I didn't know that.
Yeah. So it's not just penetration, for example, that can give you an HPV infection. So, and it is something which has got a very high, it does predispose you quite significantly to developing cervical cancer. So getting the vaccination, again, prevention is better than cure. With everything in medicine, prevent. And it's been done for years now. There's very little side effects. It's a really safe vaccination. You know, people don't feel unwell afterwards. Again, I think perhaps a post-COVID hangover is that people are a bit wary of vaccinations, and which you can understand. You know, the COVID vaccines were very new. The HPV vaccine has been around for years, and there's really good clinical trials to show how safe it is and how much good it can do. So I would say that if you haven't been vaccinated, check to see whether you're part of the criteria that you could maybe get it as an adult. And if you are in that group of, like in that school age group, please just get your vaccine, because it really can help. And
can you get the vaccination if you've already been diagnosed as positive for HPV in the past?
I think it's very individual for each person. So I can't speak for all parts of the country, and I can't speak for private medicine, but I actually just spoke to a patient about this recently. If you fulfill the criteria, you can get it thereafter. So on the NHS, I think that some of the patient groups that would be eligible for HPV as an adult are things like people who would be in same-sex relationships, people who would perhaps be involved in the sex working trade, that kind of thing, people who would be very, very high risk of developing cervical cancer, that kind of thing. So check your local criteria, but I know that you can get it privately, and anyone can get it privately.
That's interesting that it might still be effective as well.
Yeah.
So that's interesting. So obviously you talked about cervical screening rates are going down across the UK. What do you want to tell to people who are listening? To go and attend, what's your message to them?
Get your smears.
That's it, simple.
Yeah. It's never as simple as that. I would say if you're worried, again, different GPs have different availability for this, but if there was so we proactively reach out to people who haven't attended for their smears, and it gets flagged up on our system, and we call them and ask why. Mm-hmm. And often, if it is something to do with fear of pain or embarrassment, we'll talk them through that. Yeah. It's also the fear of the unknown of it's, like, they're like, what is a speculum and what are you going to do with it? So often I'll bring people in and we can show them what we do. Yeah. The other thing is that people often just don't have time. So there's a small group. So the groups that don't attend are young girls who are afraid, yes. Young ladies who are afraid, people who perhaps have been through sexual trauma where the fears are different, embarrassment, and the other one is working women. Yeah. Working women who've got kids and a job and a husband and dog and all the other things to do, and fitting in appointments in a busy life is really hard. So I would say, ask if your appointment doesn't suit you. Don't just not go. Yeah. Call and ask for a different appointment. Majority of GPs will have like an extended hours clinic, so you can go and get your smear done at 8 o'clock in the morning or at 6 o'clock at night, for example, or something like that. So it's not just within that 9 to 5 when we're all at work and doing school runs and cooking the dinner and trying to get everyone to bed. Yes. So there's some clinics, for example, sexual health clinics will often have a clinic on a Saturday. Yeah. So time is a big thing. And if you get an appointment time that doesn't suit you, please just change it to a time you can go. If you can, don't bring your children.
I don't think you're allowed to, are you?
You can do. We encourage you not to.
That's an issue, isn't it? Because you're the primary childcare.
So who's going to look after the children?
Yeah, exactly.
Who's going to look after the children? So
I think it's a bigger systemic issue. Yeah, like the fact that you feel so much, and I love that you're with your practice, you provide so much education and time associated with that. That's a lot on your shoulders. Yeah. So probably more campaigns and more education, not globally, but across nationally, is definitely needed. More flexibility with recognition that what the limitations are. I think it's developing, it's growing. Just like you said, the sexual health clinic has a special clinic for those who have had sexual abuse in the past. Yeah. So there's recognition there of the barriers and there's addressing it. But there still needs to be more, doesn't there?
There needs to be so much more. And I think that the rhetoric around you can't get a GP appointment is quite damaging. And I am sympathetic to the underlying issue of there aren't enough GP appointments. So I'm not saying that they're talking rubbish, because I know that it is really hard to get an appointment, and I know that not every practice has the same kind of staffing levels and things like that. But I'd say if you can, please try and advocate for yourself. You are worthy of saying to the receptionist, no, I can't make that time, please give me another one. Yeah. And they should be able to give you another appointment, so please do that, and please fight for your own corner. It makes me sad that I'm having to say this, because we shouldn't have to fight for our own corner to have a smear. But please rearrange appointments if it doesn't suit you. If you can, see if you can get someone, particularly if you're feeling anxious. See if you don't care about your smear. In our practice, we just say bring your kid along, it's fine. But if you're feeling anxious and it's a big thing for you, it doesn't help to have to look after your 3-year-old at the same time. It just doesn't help. Yeah. So see if you can get someone, and that might just take some of that embarrassment away and some of the barriers away. So it's really important.
Something else that patients obviously feel that we want them to advocate for themselves is the other end of the spectrum, is through menopause. Yeah. Mm-hmm. I know that a lot of patients might not realise how much your GP can do to help with menopause and menopause symptoms, because most people think they need to refer to a specialist and so forth. But there's a lot that GPs can do. So what can GPs do for patients who might think they're perimenopausal or menopausal? What can they do?
So we manage people all the way through their perimenopausal and menopausal journey. And actually, it's only the more like kind of complex cases that we refer to the menopause clinic. Okay. Menopause care is, I think, part of standard GP practice, particularly for, it's what every woman will have to go through at some point. So that absolutely should be managed by primary care, by your family physician, So I think most practices will have like one GP who perhaps doesn't necessarily specialise, but maybe takes charge of women's health and menopause care and perimenopausal care. I think with menopause, the main thing is information. So there's just not quite enough understanding of what your body's actually going to go through. And I think people just think it's all about hot flushes and your periods changing, and it's so much more than that. So information is the big thing. And actually, in our practice, it's the practice nurse. So you'll get a lot of care through the practice nurse who can give you a lot of that information. A lot of the doctors will be able to talk you through your journey. We can provide HRT. We can provide non-hormonal based support, lifestyle changes, dietary lifestyle changes are a huge, huge part of menopause care. Mental health support, huge thing. So people don't think about that at all. Everyone thinks, again, it's just about the flushes, but actually the mental health side of going through the menopause is really, really important. And
I love that that's coming through.
Yeah.
Is there a lot that because even, you've been a GP for 4 years, but obviously in training for many years along that.
Yeah.
And so much has changed about the knowledge of menopause and perimenopause, I think, in that time. And so it's understandable why people think it's hot flushes and change your periods. Because I remember back in medical school 20 years ago, that's pretty much what I was told.
That's what you were taught.
And then maybe some still primary care physicians, GPs, who are older and still in that mindset. So there's mixed experiences. So it's lovely that, what you're able to provide, having that, interest in women's health and having that. So for maybe a woman who's worried, am I in perimenopause? I feel like I'm going crazy. My mood's changing. I'm suddenly getting acne, or I'm having night sweats. But my periods maybe not really changed, or I'm on a contraceptive like a coil, so I don't know what my periods are. Am I just going crazy? But they don't feel like they won't get advocated for in primary care. What would you say to them? Would a part of it be, well, when you're making an appointment, ask for the doctor who's special interest?
Yeah, I think
and
so.
Say it can be normal. Is there anything else you'd like to say?
So asking for someone who, first of all, ask for someone who you feel comfortable talking to them about. And a lot of the changes that you expect that you can get with perimenopause and menopause is things that are slightly more personal. Do you know, like dryness down below and acne and like your boobs hurt, that kind of thing, weight gain. So if you get given one of, our older GPs who perhaps are a gentleman rather than a lady.
Yeah, and that's someone who happened to me. And someone younger than me, a gentleman.
Someone whose mind wouldn't even go there. Do you know, someone whose mind will who would say, oh, you're feeling a bit low and your joints hurt. Oh, it's probably rheumatoid arthritis. You're like, no, it's not. It's not. It's hormones. And you need to, so ask for someone who you feel comfortable with, first of all. Okay, and that can be a male or a female. I've got my male colleagues are wonderful at this stuff. They're really, really good at female health. So I'm not bashing male GPs at all, because they are really, really good. But I would say you have to ask for someone who you can talk openly with. Second of all, again, do a bit of research. So like if you put your symptoms into Google, if you just put change in periods, menopause will come up. If you put just low mood, then depression will come up. See, if you put a whole list of things, then things like perimenopause might come up. And there's really, really good podcasts on this stuff. There's loads and loads of information on menopause for people to kind of help them be well informed. So ask for someone you're comfortable with, do your own research, so then particularly if you get someone who perhaps isn't going to proactively ask, you can tell them, no, I think my low mood, my acne, my sore tummy, my weight gain, all of the other stuff, the fact I don't like my husband anymore, I think it's my hormones. and so do your own research and you can say, I feel like my hormones are against me. 10 minutes is not enough to deal with this.
Yes.
It's just not.
It's very complex to kind of go through all the holistic aspects. Like it infiltrates so many different areas of someone's life.
It does.
To go through that, assess whether it's nothing else more serious, and to give information. So how do you do it? Yeah,
so I think that perimenopause and menopause is genuinely a journey. It lasts for a really long time. I think that as a rough rule of thumb, your progesterone will start to drop sometimes as early as 35, but definitely from 40 onwards. People often think that this is a 45 to 55-year-old thing. It's absolutely not. So hormones change really far earlier than what women present with. So it's something you're going to have to deal with for a significant period of your life. So I think starting off with getting information and giving information to your physician or whoever is looking after you is really important. All the other stuff like HRT, hot flush management, all that kind of thing, that will probably come into the journey. But starting off with starting off with information is really important. And you like, as doctors, we have to spread this through several appointments.
Okay.
You can't do it in one.
Yeah.
So you start off with planting the seed, because someone comes in going, I'm really tired and I don't know why.
Or
and
then, they could be the opposite. They might be worried it's perimenopause.
Or worried, exactly.
Yeah, and then it still delves into a big topic.
So exactly. So you start off with just the basics, and then perhaps you book them in with the nurse for a little bit more information gathering. And then the next appointment after that is, okay, so what can we do? What's your symptom burden? Then you talk through those treatment options. And then, so actually it's a rolling treatment. The majority of people who are on HRT will require HRT reviews once, at least annually, once they're established. But whenever you change a dose or start something, they need a review 3 months after. So it's something that, again, you need to dedicate a bit of time to this stuff. You need to have time to pick up the phone whenever we call you to see how you're getting on with your HRT.
Yeah.
You need
time
to have
for you, but time for the patient as well.
Yeah,
you're right.
The patient needs to have time to be able to come in and get their blood pressure checked so they can still get their HRT. Do you know? So it's a journey that if you go into it with your eyes fully opened, knowing that it's not just going to be done in a year, that it's going to be something that you'll have to manage both yourself and with the doctor, and recognising that you might need to go. Lots of these women haven't been to their GP in years.
Yeah.
Do you know?
Because we're generally young,
fit,
well patients.
Yeah,
but you don't want to put people off either.
No.
Because some of these symptoms can be overbearing and infiltrate relationships, infiltrate life and everything else. So I don't think your message it's just a reality. There's going to be a lot of appointments, but that's also great to realise you're going to be given that care. Because I think some people worry you'll be fobbed off or not worry, or have to go to a menopause specialist, which is going to be 5-year wait list or something. But there's actually a lot that you can do in primary care, which is
there's so much
incredible. It's not going to be done quickly, but that's because it's a complex topic, but there's a lot of setup there, and I think that's great.
It's not going to be done in one appointment, but I would say, there are a small cohort of women that we do need to refer on to the menopause clinic. They're mainly the women who we give HRT in our practice, but who perhaps have quite specialised needs, or perhaps their HRT just isn't working, or maybe they're a higher risk group, perhaps like a strong family of breast cancer, family history of breast cancer, for example. So we do refer those patients. But what I would say is that a lot of the time, GPs can email menopause consultants at the hospital for advice. So, even though you might be on the waiting list to see the menopause specialist, often there will be someone local who will be happy to answer GP's queries. So I don't want people to think, there's no point going to the GP because I've got this specialist condition that means I can't have HRT, or something like that, because GPs often have very good communication channels between ourselves and women's health in secondary care, and we can ask for advice as well.
I think the message here is, I know some people might not have felt that they would get support, but there is the support there. So advocate for yourself, make those appointments. There's a lot that they can do. So go if you're worried, go make your appointment. I think that's your message, isn't it?
Go and see your GP. We want to see you. We honestly want to see our patients.
I want to ask you some quick fire questions. Okay. All right, just to kind of tie things off.
That's fine.
What's one myth you wish about women's health that would just be completely busted?
Do you know what? It's actually not what we have discussed here. But one small myth is that when you are pregnant, you can't exercise. And I really wish that women wouldn't. I wish that just wasn't a thing. And I think that pregnancy is very individual for each woman. Yes. And I know we haven't really covered pregnancy, but that is one myth that I wish. Pregnancy saved me during my own. Exercise saved me during my own pregnancy. And I would like to. And I know lots of women just need to rest a bit more, but every single woman is different and every journey is different. So that would be one myth. I know it's not exactly related to what we spoke about.
It's still women's health. I think
still women's health.
Yeah. I always remember someone using the analogy of the end of your pregnancy is going to be one of the biggest workouts.
Oh yeah. Getting off the chair at the end of your pregnancy is one of the biggest workouts. Yeah.
Another question I have for you is, what's one thing you wish everyone knew about the process of going to see your GP?
I think having an awareness of the appointment time is really important. And I'm not saying that because I don't want people to come in and feel like they're rushed, but it's more about an awareness of you probably only do have time to cover one or two issues properly. So when people come in with a list, they often apologise, and I often say, it's fine, book another appointment for that stuff. Pick the most important thing in the list and let's talk about that, because you're much better dealing with one thing properly than 4 things badly. And we can always book another appointment for the less important stuff. So.
And I think also, going back to what we said, is bring it up at the beginning of the real thing that you're really worried about. Because some people come in with a bit of a wishy-washy thing, but they're really worried about something, and they're kind of putting their jacket on and they leave the door and they actually bring up the thing.
Oh, by the way.
And that was their main thing. So present with the key thing and present with it early, be clear. And that way you get that, your patient will get the most out of it. It's not just for you as the GP. What's one piece of advice that was really stuck to you in your career?
Do you know, someone once told me that you're meant to have imposter syndrome. Like, as in, you're meant to be pushing yourself out of your comfort zone all the time. That is how we grow. So, and that stuck with me every single time I do things like this, for example, where you feel slightly like, oh, who am I coming in to deal with this kind of thing? And like, this is the thing, these are the things that push you and develop you and make you a better doctor and a better person. And my dad has this saying that's like, you know, if you're the smartest person in the room, you're in the wrong room, because you should always be surrounding yourself with people who inspire you and make you learn from them rather than the other way around. So that stuck with me a lot. And every single time I have that like self-doubt of, oh, I don't like this and this is really uncomfortable, and I go, no, actually, this is what you need to grow. Do you know?
I always say I'm excited to meet the version of me who's done it.
Yeah, exactly. Yeah.
But also I think having the imposter syndrome is some form of awareness of what you don't know, which is actually really good, important thing. If you're
definitely in medicine.
In medicine, exactly. So if you're too cocky, if you're too whatever, there's probably a blind spot that you're not aware of. So having a bit of imposter syndrome allows you to just have, you care,
and that's what
and
creates
do well.
That's what creates dangerous doctors. Is doctors who think they know everything.
Exactly.
And often people will go, oh, the doctor had to look something up, and you're like, well, do you know, we're generalists. We can't know absolutely everything about everything. So when you perhaps email for advice from a consultant or you refer on, that is safe care, do you know, rather than expecting that we'll just know everything and we'll be able to fix everything, do you know?
100%. And tell me, what do you do for yourself to stay healthy?
I try to go outside every day. Like some sort of, it doesn't have to be a run or a workout, but I at least try to spend some portion of my day outside. And that sounds really simple, but actually when you've got children and a full-time job and all these sorts of things, sometimes you can just want to when everyone's in bed and the day is done and you've done all your emails, you want to just go on the couch. But get outside for something, a stroll, sit outside. And I think that fresh air and being in nature is really, really important for your mental health, and just getting a bit of distance, clearing your head. Women are really, really bad at looking after themselves. They're really good at looking after everyone else, but they're very bad about looking after themselves and bringing themselves to the GP. They bring their kids, their husband, their mother, their mother-in-law. They all come to the doctor because they bring them, but they never come for themselves. And you have to make sure that you're looking after yourself, and it's only through that you can actually look after everybody around you. But
I love the fact you said it's simple. I think it's important to be simple because our lives are so complicated. So having one simple thing that you just want to achieve every day, like getting outside, is more achievable than if you made it more complicated than that. Thank you so much for coming, Harriet. I've really, really enjoyed chatting today. I think one of the overarching themes of today is the importance of women's education and empowerment so that they can get the care that they need, and that it's really important to look after yourself because you're often looking after everyone and everyone else, and that there is so much help there in primary care. Don't forget to ask for it.
And we want to see you. That's like, we want to see our patients. Don't apologise for coming in and wasting anyone's time. We want to see you. And so please come and see us.
I love that. Perfect way to end. Thank you so much to Dr. Harriet for joining us today and helping us unpack some of the most common but often misunderstood areas of women's health. If you have further questions, there are links to more information about the topics we covered today in the description below. Whether you've been putting off booking that GP appointment or just want to feel more confident in how to bring up tricky topics, we hope this episode leaves you feeling informed and empowered. To learn more or to speak to a GP online, visit onlinedoctor.co.uk.